So what is hypertension? Otherwise, which is commonly the terminology we hear from patients is blood pressure issues. So blood pressure is nothing but the pressure of the blood pushing against the wall of your arteries. So we all know that arteries carry pure blood from the heart to other parts of the body. And then once the oxygen is used up, the blood returns back by veins to our heart to then get purified in the lungs and then go back through the arteries to the body. So uh, everybody has blood pressure. Obviously, every living human being and in this planet has blood pressure because that helps to maintain flow to the vital organs in the body. And blood pressure has what we call a circadian rhythm, which means it normally rises and falls through the day. And this is going to be important as we talk about measurement of blood pressure. And a significant increased blood pressure we know can damage the heart and cause health problems if it stays high for too long. So that brings out the term hypertension, which is basically elevations of blood pressure or high blood pressure, which is higher than defined as normal. Now, what is normal? And this I can tell you, as far as I've been a medical student and now been in practice for 21 years, these numbers have changed consistently over decades of time. More so that this is probably the most aggressive definition of blood pressure, which has been released by the American College of Cardiology and the American Heart Association. So normally, I remember when I was a medical student, people used to say, well, blood pressure is basically my age, is basically 100 plus my age, which means if you're 80 years old, your blood pressure can be 180 top numbers. So obviously, that's no longer true. And you can see now normal blood pressure is defined as your upper reading, which is your systolic blood pressure, lower reading, which is your diastolic blood pressure, less than 120 over 80. Now, this number has come down. It was 140 over 90, and in the American guidelines have come way down into less than 120 over 80. And you can see that previously we used to call this range of 120 to 129 and less than 80 as borderline or pre-hypertension or high normal blood pressures. All of that terminology is gone. And the reason behind that is the cardiovascular community, medical community wants to educate the public to say that blood pressures in this range need to raise someone's awareness. Doesn't mean you need to be treated, but needs to raise awareness that it could potentially be borderline on the higher side. That is called elevated blood pressure. It doesn't define as hypertension, but it defines as elevated blood pressure. We don't use the other terminologies anymore. And then finally, hypertension is defined as stage 1. And you can again see that this number has fallen much below what we are all used to seeing, 140s, 150s. Now, stage 1 hypertension is defined as blood pressures in the range of 130 to 139. And that is the top number, the bottom number 80 to 89. And stage 2 being defined as 10 points or beyond 140 in general. Now, this is very important because people say, well, in that case, should I be actually treated if my blood pressures are elevated at a range of 120 to 129? And the answer is no. Essentially, that means you are aware that your blood pressures are higher than optimal. You have a shared decision making with your doctor to say what you should be doing with regards to lifestyle, etc., to bring these numbers closer back to the normal range. Now, what are the startling facts about hypertension? And I'll tell you these, the reasons I put these numbers is because hypertension is called the silent killer. That means people really do not have any symptoms at all, most of the times with elevated blood pressure. Unfortunately, many of the times when people present with symptoms related to high blood pressure, it can be a stroke or a heart attack, or sometimes being fatal. So you can see that hypertension clearly puts you at risk for any form of heart disease. Atrial fibrillation, which we're going to be discussing, is one of them. And the big one is stroke, which is obviously among the top 3 leading causes of death in the United States. And in 2018 alone, 500,000 deaths in the US was attributable to hypertension. And nearly half of the adults in the United States, which is about 108 million have hypertension, which is defined as a systolic blood pressure of greater than 130, as I showed you just now. And 1 in 4 adults with hypertension have their condition actually under control, which means most people with high blood pressure do not have their blood pressures under control. And many of the adults with uncontrolled hypertension have stage 2, which is that higher range of blood pressure that we commonly see. What are the other facts about hypertension? About 30 million adults who are recommended to take medication may need to be prescribed to start taking it. So a substantial number of patients actually need to be on medication. And you can see that it costs a dramatic amount for the United States of close to $130 billion each year, averaged over 12 years to just treat issues related to high blood pressure. So certain kind of did you know facts is that hypertension is directly linked to dementia. Now, how is that? We always think of dementia as an age-related disease, but hypertension causes hardening of the arteries, not only in the body, but also in the brain. And all the small vessels which are affected by hypertension ultimately lead to abnormalities in blood flow to the brain, leading to chronic damage and ultimately dementia. And this can be related to tiny strokes which happen, which people may not recognize and ultimately manifest as what we call multi-infarct dementia, meaning they present with memory loss and other things. And we do a CT scan and lo and behold, we find that there are multiple small strokes which have not been recognized. And then you can see hypertension is not a disease of older people. It is actually about 25% of adults between 20 and 44 have hypertension. So this is typically the population who does not seek medical care. They don't come to the primary doctors. They believe that they are healthy. They don't get most of their blood work done. And so you can see that the effects of hypertension, which is silent, is unrecognized, ultimately leading to the presentation later on in life. So this is one of the key points I want to emphasize is people say, well, I feel great. My blood pressure is 160 over 90, but I don't feel any symptoms. Absolutely, you will not feel any symptoms because that's how hypertension is. Many people have it, but they don't know it. And then specifically for women, pregnancy and hypertension issues. This has now garnered significant attention in the last decade with both the cardiology associations and obstetrics and gynecology associations recognizing that pregnancy-related hypertension issues, even after it resolves after pregnancy is completed, portends future risk for cardiovascular disease. So these women who have had high blood pressure during pregnancy or go into pregnancy with high blood pressure need to be followed on a periodic basis or need to make sure they follow up with their doctor on a periodic basis because there is long-standing implications for this later in life. So what are the risk factors for hypertension? So obviously one of the leading ones is just age. So as we get older, our arteries get less capable of having elasticity, which means they don't dilate and relax properly. So there is, development of atherosclerosis, which means plaque buildup, age-related stiffening of the arteries, which causes the blood pressure to climb up. Certain races like Asians, Blacks, or African Americans, Hispanics are predisposed to high blood pressure more than Caucasians. Family history. There is definitely a genetic predisposition. It's not an isolated thing. It's one of the factors amongst many which can basically predispose someone to high blood pressure. Diabetes is a very common friend of hypertension. Diabetics, literally a substantial majority, 50 to 60% of diabetics may also have coexistent blood pressure because diabetes also affects the arteries, small and big. As we all know, diabetes affects the eyes, it affects the kidneys, heart, everywhere. And the same process like high blood pressure kind of go hand in hand. And the common things that we can control, physical inactivity or lack thereof, meaning lack of regular exercise, which then links to overweight or obesity. Then unhealthy habits, smoking. So every time we smoke, the blood vessels constrict due to the nicotine effects. So, even periodic smoking can actually cause fluctuations in blood pressure, ultimately leading to hardening of arteries. And then anything too much is bad, and too much alcohol is definitely associated with hypertension. And we'll come back to it with regards to what is considered, reasonable at this time. And I'm not sure, because even that data is changing. Now it says that any alcohol could be associated with some future risk. So why should one measure their blood pressure or know about their blood pressure? So, you can see that the damage is systemic. A big damage we talked about is heart disease and stroke, but we should not forget that the kidneys have got significant impact. So the high blood pressure constantly causes filtration pressure on the kidneys to increase. And they've shown that even 2 to 3 millimeter blood pressure elevation. So I told you less than 120 is normal, the top number. So 120 to 130 may seem okay, but literature suggests that even those minor elevations in blood pressure over a long period of time can cause protein to start leaking in the kidneys. So lower the blood pressure that you can tolerate and be healthy and happy. That may be the best blood pressure for your heart, brain, and kidneys. So you can measure your blood pressures obviously at your home. If you go to any pharmacy or any superstore, talk to the pharmacist there. You can get a reasonable blood pressure machine. You get that calibrated, which means we always ask patients to bring their blood pressure machine for the first time that they purchased it to the office, so that the office personnel can check the blood pressure with the office machine and the patient's machine to make sure what the correlations are. You don't want your readings to be greater than 10, 15 points different with your home machine and the office machine. There should be a fairly decent correlation between that. So that calibration is important, so that you know what your machine can do. Or if you don't have that capability, going to any of the pharmacies now, they have digital blood pressure machines, and definitely you can get your blood pressure checked right there. How do you measure the blood pressure correctly? And this may sound kind of in a way simplistic, but this is so key. This is key for us as physicians to actually educate our nurses and nurse assistants, and also educate patients, because incorrectly measured blood pressure can lead to incorrect initiation of treatment, which may be unnecessary and or harmful. So key things. First of all, I had a patient come today and say, I get up in the morning right away, and before I do anything, I check my blood pressure. You don't want to be doing that. And the simple reason is that when you get up, your system is revving up. So you don't want to rush in and check your blood pressure. And many times when we get up, we need to either use the bathroom or something because our bladder is full. So having a full bladder increases your blood pressure. So we should not be checking our blood pressure when our bladder is full. We are waiting to go to the bathroom or move our bowels and stuff like that. Those are all physiological things which can affect blood pressure. We should not eat or drink anything significant or heavy, particularly caffeine, prior to checking blood pressure. Sitting in a comfortable chair with your back supported and relaxing. It says 5 minutes here, which is the national recommendations. I actually tell my patients, you know what? 15 minutes of physical and mental rest. Once you've completed your morning activities and your nature's call, everything, after you're relaxed, just relax for about 15 minutes. Think about something, pleasant and different. Set up your machine, keep your arms up, and your arms should be kind of at the level of your heart. You don't want your arms drooping down or up, because all of that affects your blood pressure readings. Your feet should be uncrossed. You should not be crossing your feet, because that increases your blood pressure. And then once you've done all of these things, rested your arms well, you basically put on your blood pressure cuff, whether it's a wrist or for an arm blood pressure. Make sure it is actually snug, and then don't talk, just breathe nice and normal and take your pressures. Now, no machine is accurate, right? No single measurement is accurate. Many of the new blood pressure machines which come automated can automatically give you an average of 2 to 3 readings. And that's exactly what you should be doing. You should not be taking single readings, but average your readings, at least 2, preferably 3, and then document your reading after you've done that. So here is just a simple example of how people should be sitting when they do their blood pressure, not lying down, not standing. You can see that the arms are approximately at the level of the heart. And then simple instructions, very easy. Don't stress yourself, don't cross your legs, don't get angry, talk or anything like that, and then check your blood pressure. And some people will say, my blood pressure, my heart rate was racing fast, and I immediately check my blood pressure. That's okay. But remember that if your heart is racing, your body is going to respond and your blood pressure is going to fluctuate. So that may not represent your true blood pressure when you're in a relaxed state. So nervousness about having your blood pressure taken. And this is obviously many of you who come to the doctor's office know that we have what is called the white coat hypertension or the white coat syndrome. This is some people hate doctor's offices. They said, you know what, the moment I have to come have my doctor's appointment or thing, I'm scared because they're going to tell me something I don't like, etc., etc. So that kind of scenario can lead to elevated blood pressures. So for example, when I see a patient and the blood pressure is elevated, the nurses take it right away. I usually don't even look or don't even pay attention to the initial blood pressure taken. And particularly if it's high, I basically will complete the interview, which usually lasts about 20, 25 minutes. The people are relaxed, they're talking, they've gotten to know things. And then I finally take their blood pressure again before they leave so that they have been rested. So why is this called white coat hypertension? Because this particular group, when they go home and they're relaxed, their blood pressures at home may be normal. And what we now know is that people's home readings carry more importance than office readings. I'm not saying you should ignore office readings, but the home readings carry much more value than office readings because that's your relaxed environment. That's your comfortable environment. So if you send me your home readings and I ask my patients, you know what, document all your home readings and send it to me. Let me review it. And I look at those home readings and pay attention before I make any changes in the medicine. In general, doctors will not make a decision to start treating you just because one of your blood pressure is elevated in the office. Blood pressure reading should be repeated over a period of a month to confirm persistent elevated blood pressures, particularly at home, before we make the diagnosis of hypertension. And even then, the first treatment is basically lifestyle changes for about at least 3 months, quitting smoking, exercising, losing weight, cutting back salt, and then re-evaluating the scenario. And so we've already talked about all of this with regards to eating, drinking, and how we're sitting. So what lifestyle habits can one adopt to prevent hypertension? So obviously, these are not rocket science. These are pretty straightforward, eating healthy. We'll talk a little bit about the DASH diet. Sleep has now gained dramatic importance over the last decade. We always knew this, but it is even more important now in this stressful environment. Getting adequate restful sleep or REM sleep is key because this is clearly associated with reduction in stress, heart attacks, stroke, etc. So people who get less than 6 hours of sleep, they definitely have a shorter lifespan over long period than people who get adequate amounts of sleep. And that shouldn't become as a surprise because the body has to repair and rest too. So if there is a constantly awake state with your hormones racing all the time, how is the body supposed to repair itself? The cells all have some repair to do. During that time, the brain has to relax, so sleeping is important. The other thing why sleeping is important is that during night, your blood pressure should actually come down. That's called dipping. So sometimes in order to diagnose blood pressure, we give patients a monitor they can wear for 24 hours for a few days. That's called ambulatory blood pressure monitor. This is to see what happens to the patient's blood pressure over the natural course of the day. And typically at night, the blood pressure should come down and your heart rate should come down when you're sleeping. The lack of blood pressure and heart rate coming down at night is associated with a higher risk of high blood pressure and future adverse events. The next thing is exercising. So the American Heart Association guidelines recommend that people should be doing at least 150 minutes of moderate intensity exercise or 75 minutes of vigorous exercise or 30 minutes a day, most days of the week. You can do whichever way you want. And some people say, I did 10,000 steps. That is great. Doing 10,000 steps is better than doing nothing. But a step further than that is what we call cardiovascular conditioning. And one of the most common complaints I hear from patients saying that is, doc, I walk all the time during my work. I'm at work, I'm walking, I'm getting my steps. And I say, hey, that's all great. But they say the moment I start walking, climbing upstairs or two, or start doing something a little fast, I feel short of breath. What's the problem? Well, the problem is your heart is not conditioned. You walking is good. Nobody's denying that. But you've got to cardiovascularly condition your heart. What does that mean? That means you've got to warm up, increase your heart rate, maintain a plateau, cool down. So you've got to teach the heart that it's okay for the heart rate to keep increasing. If you don't do that and just simply you're just walking around normally, that's not a lot of activity. It's good in the form of steps put in, but that's not cardiovascular conditioning. And that is why the guidelines clearly say you want to exercise so that you break into a sweat or you have difficulty in saying a sentence when you're walking, meaning you're walking fast, and you're having some difficulty in speaking. Having said that, I would say if you're not someone who exercises regularly, don't jump in and do it. There is a way to kind of get to that conditioning level in a gradual pace. Do not smoke. We talked about this earlier. Smoking clearly causes vasoconstriction and early damage to the arteries. So that definitely increases blood pressure. So to prevent it, we don't smoke. Alcohol use, what I would essentially say is people who drink alcohol, typically the national guidelines currently say that you should not be having more than 2 drinks per day for men and 1 drink per day for women. Now, there is now literature suggesting that any alcohol increases your future risk for heart rhythm problems, or memory issues and stuff like that. So we don't, and then there is literature also to say that people who had moderate amount of alcohol, the cardiovascular risk is low because your good cholesterol goes up, etc. So you can see that evidence is fluctuating on both sides, and you can look at both sides of the coin to decide whether it is good for you or not. And obviously, we don't recommend anybody to start drinking alcohol if they are not used to alcohol. So now coming back to the DASH diet, eating healthy to kind of try to prevent hypertension. DASH diet is basically a flexible and balanced eating plan, primarily focuses on almost like a Mediterranean kind of diet scenario, primarily eating vegetables, fruits, and whole grains, including fat-free or low-fat dairy products, fish, poultry, beans, nuts, and vegetable oils, limiting foods that are high in saturated fats like fatty meats, full-fat dietary products, and certain tropical oils. And the big one is limiting sugar beverages and sweets. Now, these are the national guidelines. And so, in general, when you're choosing a DASH eating plan for hypertension, etc., you want to go low in saturated and trans fats and rich in foods which have got potassium. Potassium tends to drop the blood pressure. Sodium tends to increase blood pressure. Now, the diet is a totally different lecture because there are so many different proponents of different kinds of diet. But one takeaway message that I can tell you is the culprit, the biggest culprit that we thought long time is not fat as much as it is sugar. So sugar is now considered the biggest culprit for cardiovascular disease and cardiovascular health. Not as much as fat, because everybody says eat low fat, eat low fat, eat low fat. So people were then eating a lot of carbs, and then obviously carbs have a lot of sugars that causes increased weight. It causes glucose metabolism issues, precipitates diabetes, etc. So I think that if you had to choose between sugar and fat, cutting back sugar definitely would take priority now. And the American Heart Association has recognized that sugar is the bigger culprit than fat right now. Let's talk a little bit about sodium and salt. Common question that people have is that, but remember that the amount of salt and sodium that you get in your home by adding salt to the table or home cooking is minuscule compared to the amount of salt which comes from processed or restaurant foods. 70% of the salt comes from restaurant foods and processed foods because you can't control the salt there. So people will say, well, I only have soups. And then I'll ask them, what kind of soups do you have? Oh, I get the canned soups, and it's tomatoes, tomato soup, vegetable soup. Well, the canned soups are loaded with salt. And because they have vinegar, salt, everything's for preservatives. So you have to be careful when you choose processed and or restaurant foods, because that's where most of the salt is. And here's just a breakdown All of you are, I'm sure, familiar. These are all available on the internet that you can look up. You can see that the top sources of sodium are all linked to a lot of these things that we kind of get in our restaurants and stuff like that. And you can see this is just a kind of a cartoon to show how much the sandwich has. Now, this may look a healthy sandwich like a Subway sandwich, but if we look at sodium, the sodium content may be substantial coming from the bread. What about potassium? Potassium is actually your friend when it comes to high blood pressure. In general, uh, increasing your potassium intake can decrease your blood pressure. But obviously, everything needs to be done in moderation. If you increase potassium intake, heart disease risk is low, but you should check with your doctor, particularly if you have kidney disease and other things, because kidneys clear potassium. And if kidney issues are abnormal, potassium is already retained in the body. So you don't want to be eating high potassium foods in that scenario. So always consulting with your doctor whether certain potassium rich foods are good for you is definitely important. And so here are just some examples of potassium rich foods all of you are familiar with: bananas, red potatoes, and salmon and some spinach and other things like that. Now, what about medications for high blood pressure? Obviously, we're not going to get into the details of each medicine, but the medicines work by different ways. And these are kind of the rough ways in which your doctor prescribes medicines for you. Typically, diuretics are used as one of the first lines for blood pressure because they help to get rid of sodium and water. So remember, I told you sodium and salt retention can cause high blood pressure. So the diuretics help to have a gentle removal of salt. When salt leaves the body, water leaves the body. Or you may have medicines which relax your blood vessels. Or you may have medicines which make your heart beat with less force purposefully. So because the heart is kind of asked to slow down a little bit, it doesn't push that pressure into the arteries. So in that way, it helps to reduce your blood pressure. With that said, let's transition for a few minutes into atrial fibrillation, which is very closely linked to hypertension. Uncontrolled hypertension causes heart disease, as I told you, and atrial fibrillation is a leading result of poorly controlled hypertension. So what is AFib or AF? This is the most common type of treated heart arrhythmia. This is an arrhythmia where the upper chambers of the heart, and I'm going to show you a cartoon, instead of working in sync with the lower chamber. So when the upper chamber beats once, the lower chamber normally beats once. They are in sync. But what happens in AFib is the upper chambers go wacky and instead of beating, they start fluttering and fibrillating like this. And so the lower chambers are not getting the amount of blood flow that they normally should get. And so the upper chambers are going at 300 to 350 times a minute compared to the normal 70 times a minute. And the lower chambers may go anywhere from 70 to 150 times a minute because whatever comes from the upper chamber, the lower chamber uses it to pump. So here's a kind of a cartoon showing the normal heart, right? These are the upper chambers. You see the normal heart beats normally right there, whereas the abnormal heart beats in an abnormal way because these upper chambers are not squeezing properly. So this leads to irregular heartbeats, which is what is atrial fibrillation. So what are the symptoms? Now, atrial fibrillation, in many cases, people will experience symptoms, but not all of them. We have a lot of patients who come into the office and lo and behold, they have AFib. They don't even know about it. That's good and bad. So what are the symptoms of AFib? Most commonly, people feel their pulse or they feel the heart beating fast or irregularly. That could be AFib. So that's called heart palpitations. Because the upper chambers are not pumping well, the heart loses about 20% of its blood flow. So in some cases, people may not get enough blood flow to the system, and that can cause lightheadedness, fatigue, shortness of breath, chest pain. So what are the risk factors for atrial fibrillation? Again, age is a big risk factor. AFib is typically considered a disease of age on top of which other risk factors come. So if you take people above the age of 80, a fair minority of people can develop AFib. And particularly when you get into the octogenarian age of about 90, it's very common. And that's because, think about it like our house. If you have a 50, 60-year-old house, the wirings of the house get rusty, right? The electrical system gets rusty. And so you run into electrical problems. Similarly, the heart also needs electricity. and the electrical system starts getting rusty, the pacemaker of the heart gets rusty, and that leads to irregular heart rhythms. So you can see many of the things which are linked to hypertension also cause AFib. High blood pressure is one of the leading causes of that. One big thing for AFib, particularly in the younger population, is alcohol use or overuse. So sometimes we see these young college folks who go on a binge drinking spree during the weekend, and then after the weekend alcohol binge, they come in with fast heart rhythms found to be in AFib. That's called holiday heart syndrome. So binging on alcohol is not good. Definitely large binges can precipitate irregular heart rhythms. So there are different kinds of AFib. Some people feel it as it comes and goes. That's why we call it paroxysmal. Other people, it comes and it stays for a while, 7 to 10 days to 2 weeks, and then goes away. That's called persistent. And then finally, some patients have it all the time. They learn to live with it. That's called chronic or permanent AFib. And numerous other factors are important which can cause AFib. So some of you maybe may have been unfortunate to go into the hospital at some point of your life with some infection and had brief AFib. We see this all the time where people come into the hospital with urinary infection or pneumonia, gallbladder infection, and boom, the heart goes into atrial fibrillation because of that infection and stress on the heart. Another big factor that we need to think about is people who are obese, who snore or stop breathing at night. That's called sleep apnea. You don't need to be obese to have sleep apnea, but obesity is associated with sleep apnea. So what happens is when your oxygen drops at night because you snore and your tongue goes backwards and obstructs it, that causes the heart to get less oxygen and can cause irritability and precipitate atrial fibrillation. And then you can see the numerous other medical conditions which can cause AFib. Long story short is you cannot predict it. There is also what is called lone AFib. I have patients who are less than 65, completely healthy. The only thing they have wrong is AFib. That's called lone AFib. Then I have other patients whose dad, granddads, grandmoms, etc. have had AFib. So you can also have familial cause of atrial fibrillation. So what test should you have if you have atrial fibrillation? Obviously, the most common test is an EKG or ECG, electrocardiogram. They put all these leads on top of your chest and take a 5-second snapshot of your heart. That's how we typically look at it in the office. Sometimes we may not pick it up with that, and you may tell us, Doc, I keep having these irregular rhythms. I don't know if it's what it is. So in that case, we do a monitor. 1, 2, 3 week monitor to see if we can catch AFib while you're at home when you're having this. We also typically do an echocardiogram to look to see what's going on with the upper chambers, the valves, etc. And we do some basic blood tests. So all of these are kind of the ABCDs, the important things that we need to do to check and see why someone developed atrial fibrillation. Now, before I go into that, one of the things I want to mention here is the empowerment of the patient. So you as the patient can basically take control of your health. I'm sure many of you already do that. You have a blood pressure machine at home that also gives you your heart rate. So learning to palpate your pulse, knowing what is regular and irregular, looking at your machine, and some machine gives warning saying your heart rate is 120, it fluctuates. Or you have an Apple Watch, or you have a Fitbit, or you have one of these small patient monitors. I encourage a lot of my patients to invest in those. Those are very cheap. I'm not talking about the Apple Watch. I'm talking about these Fitbits and other monitors which cost less than $100. Because how many times can we send monitors to patients? It makes little sense if people are having these sporadic episodes where we can't catch it. So I tell my patients, why don't you just get one of those devices? This plugs into the back of your iPhone, or you can have it separately. When you have palpitations, just put your thumb on the device. It automatically captures your EKG on your phone, and you can send it to me, the doctor. I have many of my patients send that to me to say, hey, doc, this is what I felt when my heart was palpitating. Is this AFib? That has become a huge thing. And the Apple Watch study of over 5,000 plus patients showed clearly that home monitoring devices empowered by patient actually can help to detect these rhythms, which can sometimes not be picked up routinely. So if you are someone who's struggling with these palpitations and your doctor, has not been able to pick it up, this is something to discuss if it is a good option for you with your doctor. I'm not saying you should go and get it, but talk to your doctor about it. Now, the biggest danger of AFib is stroke. I mean, this is huge. And the reason is the upper chambers, because they're not pumping well, the blood slushes around and clots form in the upper chambers, and that clot takes off and gives a stroke. This is devastating because it can put a patient flat out in bed or kill the patient. And so this is why patients with atrial fibrillation have to be on blood thinners. So if your doctor is recommending a blood thinner for this rhythm, there is a rhyme and reason for it, because otherwise there is a big risk of stroke. And other complications, AFib can cause heart failure, it can cause your heart muscle to get weak, it can cause your heart valves to start leaking. So personally, as a cardiologist, I am very aggressive about atrial fibrillation, because I believe that every patient needs to have at least 1 or 2 attempts to try to bring them out of AFib, unless they don't even know about it and they don't want anything to be done about it, because it leads to a host of secondary complications down the line. So how do we treat it? We'll wrap up with this, and then we can open up to questions. The most common thing is, if your heart rate is going fast, we need a medicine to slow it down. We definitely need, in most patients, a blood thinning medicine to prevent stroke. If the rhythm keeps coming back, we can use medicines, or there is capabilities now where we can put catheters in, identify where it's coming from, and stop it. And in people who actually have risk of bleeding from blood thinners, we now have a new procedure. This is not a new procedure anymore. It's FDA approved, where we can put in a device to actually close the area where the clots form the most. And that's called the Watchmen procedure. So essentially, this is an approved procedure for AFib. So if your doctor is talking to you about this procedure, because let's say you had a bleed, or you had a problem with bleeding from your gut or your brain, and you cannot take blood thinners anymore, definitely this is an option which is now approved, and a lot of patients have already gotten these procedures. So here is an example of a specimen showing the left side of the heart and the right side, very similar to the cartoon I showed you before. This is the left upper chamber, and this is where the clots, 90% of them, form. So we can now put a catheter through the right side, cross through the partition to the left side, and put this umbrella in, which shuts this area off and prevents clots from forming. So which then prevents strokes for the patients and helps to get them off blood thinners. So something to think about in people who have AFib. So I would conclude by saying, learn to take blood pressure and heart rate if you don't. Learn to take your pulse to know what is regular and irregular. Control the basic risk factors that we talked about. Many things are under your control, like exercising, sleeping, eating right. If we take our cars, the way I tell patients is, hopefully all of you, I'm sure, like me, I'm obsessed with my cars. So I take them for regular maintenance, for cleaning, for oil checks, thing. If we do that to our cars, why wouldn't we go every year to our physician to do preventative maintenance, to get our blood pressure checked, cholesterol, diabetes, and everything checked? And think about home monitors if you're struggling with blood pressure and heart rate issues, which can empower you to kind of help your doctor in treating you properly. So with that, I'll stop, and I am happy to take any questions. Thank you very much for the opportunity. I think you're muted. Yeah.
Yeah. Thank you so much. Let's open it up for Q&A.
You have, Mira, didn't you have on the chat, you have questions already?
Oh, I see. Okay. So I have one question here which says, can you stop taking blood pressure medicine? There are two sides to look at it. So remember that hypertension, in the majority of cases, is a lifetime diagnosis. So because it's a lifetime diagnosis, everything should be done to see if lifestyle changes and other things can prevent you from going on to a blood pressure medicine. But typically, once you go on the blood pressure medicine, except for certain reversible causes. For example, somebody has a tumor which is releasing hormones causing blood pressure. You remove the tumor, blood pressure goes away. Somebody has massive obesity, they undergo bariatric surgery and they lose all the weight and the blood pressure goes away. So there are some identifiable causes where you may be able to come off medicine, but the vast majority of it is what we call essential hypertension, which means it's hypertension for life. The blood pressure comes under control and stays under control while you're on medicines. So the next question I have here is, if the doctor's office readings are high, but home readings are normal, there is no need to, is there a need to still take hypertension meds? So this is what we talked about was white coat hypertension. So what I would basically say is, if your home readings are always normal, in general, that's a very good sign and you can potentially avoid medicines. But having said that, a white coat hypertension also is not completely benign. And so if your blood pressures are persistently elevated outside your home for whatever reason, you may have to look into options of whether you need to be on medicines. And one way I try to kind of cheat and figure that one out is I will do a 24-hour monitor, which I told you about, so that I can see what your readings are throughout the day. What's going on at home in the morning when you're doing all your activities. For example, let us say you're doing work and then you start exercising and your blood pressure goes up to 220. That's not normal. So I use those clues. I may use an echocardiogram and an EKG to see if your heart muscle is thick, which can give me clues that blood pressure is affecting your heart. And I use all of that information to make a decision if I do have to start you on medicines. But home blood pressure readings are still the most important. So what is the connection between BMI and high blood pressure? So BMI is body mass index, and typically it is, it is what should be your weight for your height. And there are charts available that you can look up, you can plug in, you can go online and plug in your height and weight and get your BMI, and then the other. And in general, the answer to your question is there is a almost linear relationship. The greater your BMI, the greater the load that your heart has to face to pump the blood, right? So if your BMI is 24 and versus your BMI is 44, there is so much more excess tissue that the heart has to pump blood to. So clearly that is going to cause issues with higher blood pressure. And we know clearly patients who have lost dramatic amounts of weight that's an example of getting off blood pressure medicines very, very clearly. So there is a direct important relationship. Can we download the slides for the presentation? Sure, I can send a PDF. I would suggest that you don't share it for any other uses, but for educational purposes, I will definitely send it. And then someone asked this question. Oh, okay.
No, I answered it because we have this recorded and we are going to post it on our website.
Perfect.
Actually, all our seminars will be posted there. We've already got agreement with Henry Ford Hospital.
Excellent, excellent.
Yeah.
And then someone asked a question, medication causes the heart rate to be below 50. Is that a problem? So as I told you, one of the group of medicines which treat blood pressure are medicines which slow down the heart purposefully. Like example, beta blockers like metoprolol, atenolol, or calcium blockers like cardizem, verapamil. So they work in different ways, but one of their primary ways is they do decrease your heart rate. Now, in general, I don't use a certain number to tell patients this is too low, but in general, I don't see the point of heart rates being in the 40s, because that's essentially kind of driving down the heart too low. If you're feeling well, I do have patients who run 47, 48, they're feeling great, the blood pressure is okay, I leave them alone. But in general, it's a little bit it gets into the too low range in general. So, rather than saying it's too low, I would say everybody is different. You'll have to see what your normal trends are, talk to your doctor and see if that is okay for you. Does taking a nap during the day count towards 7 hours of sleep? So I presume you're talking about power naps, and the answer is no. So there is a difference between consistent restful hours of sleep versus taking naps during the day. And actually taking a nap during the day, if you have the luxury to do that, is great. Actually, they've shown that people who take short naps during the day where they're able to kind of turn off their system, get refreshed and start, but that's not the same as having continuous REM sleep or relaxed sleep do that. Now, important to just make sure is that if you're napping during the day because you're not sleeping at night, that's not normal. That happens typically in people with sleep apnea. They don't get restful sleep during the night. So in the daytime, they're tired and they have to kind of nod off or nap off frequently. That's not normal.
Okay.
So should there be concerns if the heart rate is consistently around 90? Well, the normal heart rate is between 70 to 99, if you want to say, or between 60 to 99, you can say that. So, the way I look at it is that in general, there are two systems in the body. One system which keeps our heart rate up. Let's say we are frightened, excited, angry, or something like that, the heart rate goes up. That's called the sympathetic system. For the fright and flight, we run, heart rate goes up. Then the other system which keeps our heart rate down, relaxed, sleeping at night, etc. So the balance between these two systems helps to decide our system in general. So some people are a little bit hyper. Their heart rates are always 85, 90, 95. Then you have other people who are a little bit hypo. Their heart rates are in the 50s to 60s. Not to say that one is worse than the other, but I would say in general, a lower heart rate is preferable long-term to a higher heart rate. Because if the heart can function efficiently at a lower heart rate, it's using less energy. So I would say, if it were me, I would prefer that the heart rate consistently be between 65 to 75 or around 80. So that's the answer. I wouldn't say it's bad, but I would say probably in the long term, it's better to have a slower heart rate.
Doctor, I have two questions. They're related, okay? First one is that if the blood pressure above 140, there are going to be some kidney cells being killed, correct?
Well, I wouldn't say killed. It's basically the kidney is definitely exposed to stress. So long term, you're right. Long term 140, 150, 160s leads to kidney damage. Absolutely.
Right. So if I do cardiovascular exercise, that heart rate goes up, so are the blood pressure sometimes. Okay. Yeah. Then if, say I'm an athlete, I do dash, and then a lot of times it goes up beyond 140. Does that kill the kidney cells too?
No. What we are talking about with regards to blood pressure damage is a consistent blood pressure trend. We're not talking about exercise related. So normally when you exercise, your blood pressure goes up depending upon the duration of your exercise, 10, 15, 20, 30 points. That's okay. Just like the heart rate. That's a normal response. Because remember that when you're exercising, your muscles need blood, right? So the heart has to increase the heart rate and the blood pressure to supply that. That's physiologic. That does not lead to sustained damage to the kidneys. The damage to the kidneys comes from sustained blood pressure.
Okay, so then in other words, that your kidney does not have replacement or replenish function, right? Once it's killed, right?
Once, again, if it is due to long-standing hypertension-induced damage, what is damaged is damaged. Yes. There are certain reasons why we can get back kidney function, just like I told you why we can get rid of hypertension. Those are very specific causes. Hypertension-related kidney damage, once it happens, we need to prevent it from progressing.
So there's another question in the chat. Is the low diastolic pressure okay?
That's a very good question, actually. So, too much is too bad in anything, right? So, for example, I told you that your preferable readings of lower blood pressure is anywhere between 70 to 80, right? When you start blood pressure medications, even though we are primarily we are trying to get the upper reading down most of the times, the lower reading also starts going down. But there comes a point where when the lower reading falls, particularly below 60, where it has been shown that particularly in people with history of heart disease, like coronary artery disease prior heart attacks, prior strokes, etc., very low bottom numbers can be damaging in the long term. So we typically do not recommend the lower readings to be less than 60, particularly less than 55 for sure. Yeah. So that may require a little bit of recalibration of your blood pressure medicine, but it is challenging. I'll tell you, sometimes your upper readings are still high at 150 and your lower readings are already 55 to 60. So your doctor is kind of stuck as to how to kind of handle those scenarios.
Yeah.
Those are very challenging ones. Yep.
So any other questions? In the meantime, I do have one. Can you comment on the use of trans fats and also palm oil? What is the effect on blood pressure and heart disease?
I think in general, trans fat is bad. And, trans fat and, palm oil is not recommended. It's not recommended for cardiovascular in general, long term. And these oils, particularly, it's not like they will directly have an effect on blood pressure. They indirectly, the trans fats and other things have effect on blood pressure by inducing hardening of the arteries. It's promotion of atherosclerosis, which causes hardening of the arteries, which then lead to blood pressure in general. So if you look at the industry, food industry, they've eliminated most food industries of fast foods have been demanded to eliminate trans fat from the residual oil cooking and other things. Yeah.
Right. Okay. Okay. So there's another question: is hypertension a problem?
Well, if it's hypotension, which is symptomatic, absolutely. Meaning, what is it due to is the issue. So, for example, my family member, one of my family members, she's a small build, she's young, etc. and stuff, and her blood pressure is 90 over 60. Many women run blood pressures of 90 over 70 or 90 over 60. That's their body. In general, smaller build, petite women tend to run lower blood pressures. That is called hypotension. That's their range. Hypotension is when you go from your actual blood pressure readings dramatically dramatically below, which causes symptoms. So, for example, if your blood pressure was 140 over 70, and suddenly your blood pressure drops to 110 over 70, and you feel lightheaded and dizzy, that's abnormal. Even though the blood pressure 120 or 110 over 70 is okay. Whether it's good or bad, some people function at a certain blood pressure range. So if we tweak the medicines too much, where the blood pressure drops, some people may get symptomatic, even though the blood pressure is in a decent range. Same thing with diabetes, right? Some people, if you drop their blood sugars from 150 to 120, they will get hypoglycemic. Mm-hmm. So hypotension definition is depending on what causes you to be symptomatic. So if you're dehydrated, your blood pressure is going to be low. That's bad. You need to get hydrated. Same thing if you take too much blood pressure medicine and you drop your blood pressure and get lightheaded and dizzy, that's bad. So that needs a recalibration.